Hi, everyone. Good morning. Today, we're joined by Dr. Stenehjem to give our weekly COVID-19 update to the community. Dr. Stenehjem, thanks so much for joining us. It's nice to have you on.
Thanks, Amanda. It's good to be here.
Yes.
I even wore a jacket for the occasion.
It looks very nice. As always, we're going to do case counts first and kind of talk about what's been happening. These numbers are from yesterday, just so everyone is aware who is watching. The daily case counts from yesterday was 1,687, which is up 196 from the previous week. School-age case counts are also now being reported, and yesterday's was 413, which makes up 24.5% of the case counts yesterday. We had a total of 12 deaths yesterday, and our hospitalizations sit at 498, with our 7-day positive rate at 14.1%. Let's talk about that a little bit. We've talked about capacity before. How are our ICUs and our hospitals doing right now?
Yeah, so right now, looking at our occupancy board, we are 99.5% full in our COVID hubs. And so those are our large hospitals centered here in Salt Lake, Provo, Ogden, St. George. So we're 99.5%. So we are at capacity. And we've got approximately 1 bed available. And across all of our ICUs, across all of Intermountain Healthcare, we're at 98% capacity. And so we are full. We are completely full with both COVID patients and non-COVID patients alike. And it is, a significant struggle to be able to find beds for patients that need that higher level of care.
And how are our caregivers feeling? Is there any sense of relief happening at all, or what are the feelings like in our hospitals right now?
No, everybody's, the morale is really low in our hospitals. It continues to be really low. And I think what is really concerning for our caregivers and for us as an organization is that, cases may be plateauing, total cases may be plateauing based on the case counts. The rate of rise isn't as high this week as compared to previous. That being said, what we're really nervous about is what's happening in children. And so we're seeing this really significant increase in school-age kids. And granted, kids don't often get severe illness, but what we do know is that kids can transmit the virus. And so as we see this increase in cases in kids, what that we know will happen is that they then bring that virus home, transmit to mom, to dad, to grandma, to grandpa, to other community members. And then that fuels more hospitalizations in the adult population. And so the big challenge for us is that, we don't see an end anytime soon. And so that, as a caregiver who's been in this, since, really February of 2020, that's really challenging on morale to know that, there's just more to come.
While we're talking about schools, let's talk about a couple of comparisons between last year and this year. I mentioned this earlier that 24.5% of the cases from yesterday were in school-age children. What is the difference between last year and this year around the same time?
Yeah, so I would say last year, throughout the whole school year, we did relatively well. We were actually pointed to as an area that was able to keep kids in school, that had low transmission rates. There was an article published in the MMWR last March that really highlighted the low transmission in our elementary schools. And I would say that last year we had a really laser focus on preventing transmission in our schools. And so there was a focus on distancing, focus on hand washing, there was mask requirements, and there was significant people doing hybrid school. So that was a decreasing the number of people in our classroom. And so it was hitting on all of those elements of preventing viral transmission of COVID-19. And we were able to keep schools in session and we were able to move forward. This year, different story. Now we have a more transmissible virus. Okay, so Delta variant is certainly much more transmissible than the wild type virus and the Alpha variant that we had. And there isn't universal masking across the state. There is in the Salt Lake district, and but we aren't seeing universal masking in other places. And all the kids are back in school. So there is very little hybrid, going on right now. And so that's the difference, is that last year we had a less transmissible virus and we had a lot of public health initiatives in place. This year we have a more transmissible virus and very little public health interventions in place. Granted, those kids that are 12 and up can be vaccinated, but we know that the majority are not vaccinated. And so we have a very transmissible virus in schools that have very close indoor settings where there's teaching and talking and yelling going on. And we're seeing transmission in that age group. And I suspect that we'll see much more of that in the weeks to come.
I want to talk a little bit too around, you mentioned that Salt Lake City and Grand County have a mask mandate. There's been talks about this comparison of those counties versus the others. When could we actually see, like, how long do we need to wait to kind of determine if that's, quote, working?
Yeah, it's an incredible natural experiment, right? That you've got two school districts really close to each other, similar demographics of children and kids in it. One has a mask, mandate, the other does not. And so this is really going to test, I think, the power of the mask in terms of how effective it is. Granted, we don't know how many people in Granite are wearing masks and the like, but what we hear from Salt Lake District is that the majority are wearing masks. And so I think it will be a really interesting experiment from a masking standpoint. And I think in a couple of weeks, I think we're going to be able to take a look and say, is there a difference here? Is there a difference between case counts in these counties that with and without masking? And I think it's going to be pretty evident.
You mentioned this briefly earlier about this impact of children getting sick and then kind of passing it along. What could be the long-term impact of that if schools continue to have high case counts? What kind of flow could we see happen to other people in the population?
Yeah, so I think if we're starting to see this rise in kids and that continues, then you're going to see that transmission to adults, parents, grandparents, the vulnerable, those that are unvaccinated, not protected. And so I would imagine that we start seeing that spill over into hospitals, probably within 3 to 4 weeks, if that sequence of events occurs. The other really big challenge is the effect on the private sector in terms of missed work. So if your child has COVID-19, they stay home, they're quarantined they're isolating for 10 days. That typically means that mom or dad need to stay home from work. That's absenteeism from work. And so that ripple effect is really significant. Not only are they out of school and not participating in learning and education in that social environment, but mom or dad may have to stay home and then also not work, and that has financial implications for the home. And so I think it's not just the hospitals, but it's also those other implications of positive tests in kids.
A question around that too, if your child is exposed, do you also need to isolate? Like how does that exactly work? If someone who you live with gets told that they had an exposure, does that mean you have to also isolate as well?
No, so if a child is exposed, depends if they were masked or not, and then kind of depends on when they get tested to be able to come out of quarantine and the like. But you, as a contact of that exposed person, doesn't need to quarantine. It's second order transmission. So only if that person that was exposed develops symptoms, then you are now an exposed person from that infected individual. That's when you would quarantine. So it really is focusing on you as an individual if you've been exposed to somebody.
Got it. That makes sense. I want to switch a little bit to talking about the vaccine, specifically the third dose. Can you kind of explain? So I know that it's immunocompromised people can currently go get the third dose, but how does this work for the general public? At what point does it kind of get an all clear to go get a third dose?
Yeah, so right now the third dose is only available for people that have immunocompromising conditions, those that have received a transplant, those that are on medications that lower your immune system. Those people are eligible for a third dose. And keep in mind, There are lots of vaccine series that have a dose at 6 months, for example, hepatitis B, hepatitis A. There's a number that have a third dose in the series to really kind of protect that long-term immunity. And so having a third dose in a vaccine series is very, very common when we see that in a lot of vaccine series. And so right now, a third dose is available for those that have immunocompromising conditions under an EUA. So under the FDA Emergency Use Authorization, you can get a third dose for immunocompromising conditions. Now, a third dose or a booster shot in the adult population that don't have immunocompromising conditions, that hasn't been approved yet by the FDA. And so for the general public, there is no third dose yet. What's happened is that the Biden administration is saying, we want third doses, booster shots to start on September 20th. What happens next, though, is it has to go to the FDA to get approved for an EUA, emergency use authorization, for the general public for a third dose. Okay, so that is set to go to the FDA. Pfizer's turned in their application materials. They're going to be reviewing that to determine whether or not the FDA is going to grant an EUA for the third dose. If they grant an EUA for the third dose, then it goes to the ACIP, which is an offshoot of CDC, to recommend to the general public that a third dose is safe and effective. And so that's the timeline. And, you know, it's September 3rd today, and a lot has to happen in order for that EUA to be approved and ACIP to recommend it to having shots in arms, you know, September 21st, 22nd, 23rd. So I would not say it's a foregone conclusion that we're going to be boosting people starting September 20th. There's a lot that has to go into that and a lot of hurdles to get through. But that's the timeline that, you know, the Biden administration is certainly pushing for. And so we'll see if all that happens. Here at Intermountain Healthcare, we're preparing for this. We're getting ready to say, okay, how are we going to do this? Because it's going to roll out first to those people that have been vaccinated for at least 8 months. And so who is that? That's healthcare workers, because we got vaccinated December into January. And so we're now at that 8-month mark. And then it's people that are older age. So you think about how that got rolled out in our community. It was first-line caregiver, healthcare workers, people that are older age, and then it kind of rolled through. So we're going to have to go through that sequence again to get boosters. So we're getting prepared for it if and when the FDA grants an EUA for it.
What about having FDA approval for those 12 to 15? I know the current dose is 16 plus for Pfizer. Do we have any timelines on that 3-year age period?
I have not heard any timelines for that, particularly as it relates to boosters at all.
And what about an EUA for 11 and under? I know that's a huge topic, especially with schools going back. Do we have any updates on that?
So last weekend from a Pfizer board member was that they hope to have top line results out by the end of October. That would mean then an EUA application to the FDA very shortly thereafter. And then generally, when we look back and say, how long has it taken FDA to go through these applications? It's been 4 to 6 weeks. And so that puts us really at the first part of December as a potential EUA for what we anticipate would be the 5 to 12-year-olds. The 5 to 12-year-olds are the people that are going to be evaluated next. And so that's our timeline that we, you know, really are our best guess of the timeline. And again, we'll see. It has gone faster in some areas and slower in some areas. The FDA has really tried to make sure that this study in kids really shows the safety and efficacy of the vaccine. So they've required more people to be in the study, and they've required the follow-up period to be longer. So as opposed to the adult studies, which had an average of 2 months of follow-up, in the kids study, they're requiring 4 months of follow-up. So that's part of the delay, and they needed to get more people into the study. And so I think that's part of the reason why it's now been pushed back into December.
Someone just asked a question around if they should get an antibody test before getting the third dose, if they're eligible for the third dose. Any thoughts on that?
Yeah, so we have not, there's really no good data to suggest that a positive antibody test is a correlate of immunity. And so yes, there's antibody tests out there, but it doesn't tell us anything clinically at this point. And so it would really have no bearing on whether or not you get a third shot or not. The antibody test right now is yes or no. Do you detect it or not? And really, to understand correlative immunity, you need to know what level of an antibody do I have that signifies immunity or protection against SARS-CoV-2. And right now, we don't have that information. And so getting an antibody test doesn't help you. The other challenge is that there's multiple different antibody tests. And so you can get an antibody test to the spike protein, and you can get an antibiotic test to the nucleocapsid protein. Now, if you are vaccinated, your spike antibody is going to be positive. If you are infected, both your nucleocapsid and your spike protein will be infected. And so let's say you're vaccinated, you hadn't been previously infected, and you go get an antibody test and they order the nucleocapsid antibody. Well, that's going to be negative just because you haven't been exposed, and that's not what the vaccine targets. And so there's a lot to be kind of unpacked there in terms of antibody. The simple answer is no, it has no relevance to a third shot, and we don't know how to interpret the data.
What about the effectiveness on the Delta variant right now with the vaccine? Do we have any more data around how that's particularly doing?
Yeah, so over the past month, there's been a series of studies that have come out from all over the world. So out of the UK, out of Israel, some out of the US, all showing that the vaccine effectiveness, so how well the vaccine prevents an outcome. So whether that's hospitalization, whether that's a positive test, whether it's an ER visit, show that it remains still very effective, but not as effective as that 94, 95% that we saw in the clinical trials. And so the numbers kind of have gone up and down depending on the study methodology and depending on how they assess the outcome. What was reduced? Was it hospitalization, ICU, positive test? And so it's varied across that between the low of about 60% of vaccine effectiveness to a high of 90 plus. What we know though is that it is still very good at preventing hospitalization. And that's what we care about, because hospitalization leads to death in terms of that sequence. And so if you can reduce hospitalization with the vaccine, we're going to reduce death with the vaccine. And the vaccine effectiveness in the Delta period, preventing hospitalization, is still very good in the 80s. The challenge that we have is assessing, is this reduction due to the Delta variant? Okay, because this is a new variant. Does this escape our immune protection? Or is it due to waning immunity? Because people, now have been vaccinated, some people 8 months, like myself, I got second shot in January, so I'm 8 months out. So is that decrease due to waning, or is it decrease due to the Delta variant? That's the hard part to kind of untangle. And if it's due to waning, well, then another shot may boost your immunity, and so you now have some protection. And so data is coming out of Israel, this week, looking at how effective their boosting program has been, and the initial results look good, showing that it does reduce infection in those that have been boosted. And that's the first data we have in terms of the effectiveness of boosting. So I think the takeaway message is that the vaccines are still great. They provide really good protection against hospitalization, even in this era of Delta. And that is really our main tool to really move past this wave of the pandemic.
I want to talk a little bit about vaccine breakthrough cases. How are these different than someone who gets COVID-19 who is not vaccinated?
Yeah, great question, and something that I think we really need to focus on and emphasize. And so here within Intermountain, we're looking at, of the people that get admitted to our hospital with COVID-19, what percentage of them are vaccinated versus unvaccinated? And so currently right now it's a 90-10 split. So of the people being admitted with COVID-19 to our hospitals, 90% of them are unvaccinated, 10% of them are vaccinated. When you look at the ICU data, and just looking at patients that are admitted into the ICU for COVID-19, 92% of them are unvaccinated, 8% are vaccinated. Okay, so that's great. That shows us this vaccine is working really, really well. Now let's take that a step further. Let's say, what does the population look like that are in our hospital that with COVID-19 that's vaccinated compared to those that are unvaccinated? So those people that are in our hospitals with COVID-19 that are unvaccinated are younger and they have very few comorbid illnesses. Okay, so their average age is 53, and the majority of them have either one or none comorbid illness, things like high blood pressure, coronary disease, diabetes, obesity. So the majority have either one or none, okay? As opposed to those people that are admitted to our hospital that are vaccinated in COVID-19, those people are older and have significantly more comorbidities. So that group, average age 69 compared to 53 in the unvaccinated, and their average number of comorbidities is 5. Okay, so 5 compared to 1. And so that means they have high blood pressure, diabetes, heart disease, obesity, cancer, any number one of those comorbidities. They have an average of 5 of them. So those people that have breakthrough infections that land them in the hospital are the people that we know are not going to respond well to the vaccine, right? So they're older and they have multiple complicating comorbid issues. Those are the people that we know fail vaccines, whether it be influenza vaccine, pneumococcal vaccine. Those are the people that we expect that are going to get breakthrough infections. We're seeing very, very few young, healthy people come into our hospital after being vaccinated with COVID-19. People that we see come in the hospital that are vaccinated are the older and have multiple comorbidities. So that tells us 2 things. One is like, get vaccinated, because we see young, healthy people in our ICUs, on our floors with COVID-19. You don't have to have any comorbidities. Just don't. Delta is certainly more severe. And if you are older and have been vaccinated, you still need to be careful. You need to be safe. And in order to protect those people, we need everybody else to get vaccinated. And we've got to lower the community transmission of COVID-19.
Question for you really quick about unvaccinated versus vaccinated. A lot of people have said, well, if they're unvaccinated, maybe they received 1 dose and that's why they're in the hospital. Do we have any data around like if they've had a dose and that they're in the hospital?
So I don't have that at my fingertips. We are part of a large study that's going to be coming out next week and looks at the vaccine effectiveness of no vaccine versus 1 dose versus 2 dose. And 1 dose of the vaccine is not at all as good as 2 doses of the vaccine. You really need that 2nd dose to get that vaccine effectiveness up in that 80–90% range. 1 dose is better than no doses, but that being said, it's not nearly as effective as the full series. Just does not give you that protective immunity that you need to prevent hospitalization.
Is that the next Friday?
Yes.
PSAO meeting? Okay, so we'll post that for everyone if you want to watch that and hear a little bit more about that conversation as well. 2 more questions around the vaccine for you. So now that Pfizer is FDA approved, they were given the opportunity to name the vaccine, and there's a lot of confusion and misinformation right now that this name is a different vaccine. Can you kind of explain how that works from an FDA standard? I think you may be frozen. Eddie, can you hear me? Okay, we are experiencing some slight technical difficulties. I think you're back. You're back. You're on mute though. Yes. You know, after 18 months of this, that's like the first time that's happened, so I'm proud. Did you hear my question, or do you want me to ask that again?
I did not.
Okay, so now that the FDA has approved the Pfizer vaccine, they were given the opportunity to name the vaccine, and there's a lot of confusion that this named vaccine is different than what people have gotten. Can you kind of clear the air on that?
Yeah, same thing, same exact product. It just now has a trade name. I don't even know what it is. It starts with a C. Commodity. I'm not sure what it is.
It's like commodity, something similar to that. Yes. Yeah. Okay. So same vaccine.
All that is a brand name, just like the brand name of acetaminophen is Tylenol. The brand name of ibuprofen is Advil. So all that is a brand name that they can market. Same vaccine, no difference.
So it's almost flu season as well, and flu vaccines are now being given out at different locations. Some people can get them at the same time as their COVID vaccine. Do you have any recommendations for people as we go into flu season with getting the vaccine as well?
Get it, get the vaccine. We have no idea what this season is going to look like for influenza. Nobody does. Last year, we had essentially zero influenza. We had essentially zero RSV, and we had essentially zero other seasonal respiratory viruses. The reason we had that, people were masking, there was essentially no travel, there was social distancing, we weren't congregating in crowds, and we're all wearing masks. Okay, this year, we're seeing a really significant surge in RSV right now. That's what's filling up our primary children's hospital. We're seeing high cases of RSV. Kind of a traditional spike of RSV that we see in the winter is now happening right now in the late summer, early fall. So that just tells us that we have plenty of viral transmission, right? That tells us that our public health issues, our public health, initiatives aren't in place. We're not masking. We're seeing this significant transmission of RSV, and we're going to continue to see significant transmission of seasonal coronaviruses, rhinovirus, paraflu, all the other stuff that we see. So what that tells me is that we are in an environment where we can have the transmission of influenza. And so it's really just a matter of when do we see influenza coming into our communities and causing the things that influenza does. And in cases in previous years, that causes severe infection in the elderly that leads to hospitalization, and also in pregnant women. And so as a method to decrease the burden on our hospitals, we got to get influenza vaccines out there as well. And so this is your annual influenza shot. Go out and get it once it's been offered. We've got a long track record of influenza vaccination, and you can get your influenza shot the same time as you get your COVID-19 shot. That's absolutely fine. Our recommendation is, like it was last year, is get out and get vaccinated for flu.
Almost done for you, but one quick question before we get into those last ones. Somebody asked if you have any recommendations for a good home test, like a take-home COVID test. Do you have any that you'd recommend for people if they want to do that?
Yeah, so right now, the one that's on the market here locally that I've seen the most is something called the Binax Now. It's a home antigen test, and it's actually really easy to use. Their costs are between $20 and $23 for 2 tests. You can get them at Walgreens, your local drugstores. They come kind of in a purple box like this. And the tests are really easy to do. It's a swab in your front part of your nose. You put it in this little card, you put some drops on it, and you shut the card and you wait 15 minutes, and then you read it, whether you have 1 line or 2 line. So really simple to do. The tests are pretty good. So if you took 10 people that had active COVID-19, it would detect and have a positive test for 7 out of 10 on average. Okay, so it's not perfect. It's not as good as our PCR test, but it's okay, right? And so it is something nice to have on hand. And if you have symptoms, you can do that test. But if it's a negative test, and you really, potentially have COVID, you need to go and get a PCR test. And so it's something that, our family has on hand. And if somebody has symptoms, we'll quick swab them. If it's negative, then we'll have to go and get a PCR test. If it's positive, you got COVID. Like it's good. If it's positive, you can stop. But if it's negative, you really should get that followed up by a PCR test. And so they're good. I think that's great. We got to get more of them out on the market. We got to get that price down from $10 a test to more like $1 a test. And so then this could be something that people use on a routine basis, right? You can even imagine kids swabbing before to go to school if the price was right. And so there's a lot of utility in these types of tests, but 1, we need more of them, and 2, they got to be cheaper. But they are available, and I would say people should use them.
What are some things that we can be doing now to start reducing hospitalizations as we move forward?
Right. So there's things that we can do now that are going to affect hospitalizations this week, right? And there's things we can do now that are going to affect hospitalizations in a month. Okay, so the things that we can do now that can prevent hospitalizations immediately is that if you have symptoms, get tested, and if you're at high risk for complications, get a monoclonal antibody therapy. Okay, so we know that monoclonal antibody therapy in high-risk individuals, so that could be either advanced age or multiple comorbidities, unvaccinated, in those individuals, if we give you timely monoclonal antibody therapy, we reduce your hospitalization significantly, reduce the risk of hospitalization significantly. But you have to be within 7 days of symptoms, and you have to be one of these high-risk people that has a high likelihood of going on to hospitalization. And so that is something we can do immediately. If you have symptoms, go get tested immediately. And if you're positive, get evaluated for monoclonal antibody therapy. That's going to reduce our hospitalization burden immediately. Okay. And so what can we do to prevent hospitalizations moving forward? Is we got to get back to our public health principles, right? So if you haven't been vaccinated, get vaccinated. Okay. This virus is so transmissible that if you are not vaccinated, if you're still susceptible, you're going to get this infection. Okay, unfortunately, that's just the case of it. And so vaccination is absolutely number one, the most important thing that we have to do. Second, so we got to get back to wearing masks. This is our tool to not have to social distance. This is our tool to maintain our businesses being open. This is our tool to maintain our kids in school. This is a simple tool. Is it 100% effective? No, nothing is. Our vaccines aren't 100% effective. But that said, it is not a major sacrifice for us to put on a mask if we go in to indoor public places. If we go to Costco, if we go to a gas station, if we go to a grocery store, put on a mask, okay? Because that is going to really reduce community-based transmission. And then the third is really avoid large congregate settings. This is where we see transmission. And we just have to get back to those public health principles, and we need to be able to bring these cases down. And so we open up room in our hospitals, especially as we move into the fall, as we start moving into, the holiday season. The last thing we want to do is go into the holiday season with numbers like we have right now. And our caregivers just need a break. So those are the things that we can do now to really prevent significant hospitalizations, in the next, 4 to 6 weeks.
Eddie, is there anything else you want to mention to us today before we sign off?
Just the power of vaccination, I think, is the thing that we should leave people with. And there's a study out yesterday in Lancet Infectious Disease that looked at, it was over 1 million people in this study. It was done in the UK via this app. It was just an elegant study that looked at people that had been vaccinated and got infection compared to those people that got infection without vaccination. So it looked at breakthrough infection in those that are vaccinated and those that had just gotten, infected without vaccination. The people that had been vaccinated and still got infection were half as likely to have symptoms at 28 days. So they reduced the chance of developing long COVID by half. They also reduced the number of people with 5 or more symptoms in half. And so even if you have a breakthrough infection after being vaccinated, the chance of long-term complications is dramatically reduced. Okay, so if we have to summarize, this vaccine is safe and it's really effective. It's effective at reducing hospitalization. It's effective at reducing death. Any kind of ED or urgent care visit, it's effective at reducing that. And even if you did get infected after the vaccine, your chance of developing long COVID is cut in half. The chance of having to go into hospital is reduced. So these vaccines are just incredible. We couldn't have asked for a better vaccine and this quick in the pandemic. And so what I'd leave people with is, please understand that this is a safe and effective vaccine. And we have to utilize this to get back to where we want to be in our communities. And until then, until we get people vaccinated, we got to focus on public health measures, and that's wearing a mask, washing our hands, avoiding congregate settings, minimizing some of our contacts, and being really careful around those people that are very vulnerable to this infection.
Thank you. That's really great advice. And if anyone is watching would like to get vaccinated and has not yet, they can go to intermountainhealthcare.org/COVID vaccine. We have a lot of articles that are going up that are new from these lives and also from other experts around the vaccine and its safety, as well as a link to where you can get the vaccine itself. You can also go to coronavirus.utah.gov to find other state locations as well. Eddie, as always, thank you for joining us, and we'll talk to you later.